When we enter school to learn, our trades as healthcare professionals, we're taught about self-care, about taking care of the caregiver. And we learn things like, if you feel overwhelmed, talk to your supervisor and let them know. And we want you to have good work-life balance. And, if something's not working well, just call for help. Someone will be there. And then we get out in the workforce and we find that the demand for what we do frequently exceeds the supply of people who are able to do it. And so we kind of put our head down and take care of our patients and our coworkers. We do whatever it takes to keep our clinics running and our systems running. And before you know it, that healthcare, that self-care is completely forgotten. And then we function that way for a long time. It becomes our modus operandi. And then we become what we call burned out. And in talking with Chad and Mark and some of our fellow members of the Scientific Advisory Board, we felt like this was an important enough topic to talk about at the meeting. And so we decided we needed to find a national expert, and we did. We found and asked Dr. Ihwaria Subbiah to come speak for us. Dr. Subbiah is a healthcare leader specializing in palliative care, integrative medicine, and medical oncology, with more than 16 years of patient care experience and progressive scientific and administrative responsibilities. She has expertise in navigating complex health systems and a solid track record of successfully launching large-scale evidence-based programs. Her academic career is very impressive, and she did her fellowship training at MD Anderson and is now moved on to a leadership role with Sarah Cannon Research Institute and U.S. Oncology, where she's developing and launching the first network-wide comprehensive clinical well-being program. Please welcome Dr. Subbiah.
Okay. I keep my phone here, I say for timing purposes, but my husband is also at home in Nashville watching our 3 children, and I'm just waiting for that exclamation-filled text to come through. But he insists he's knocking it out of the park, and I fully believe it. This is my first CAGLA, and this is a phenomenal meeting. And that is in no small part thanks to the people across the room, but especially at this table. Chad, please, and Mark, can we give a round of applause for the 2 of them? It is definitely going to feel weird going into work on Monday and just not getting emails from Chad. Like, I know everything about how to park here, and I don't rent a car. And so, among other things, when you think about all the events that we've had and the opportunities to have conversations with people you know and meeting new folks, coming together over a common interest, whether it's the speaker on the stage or whether it's something that caught your attention, this is peer support in action. This is building community. This is central to a sense of belonging in the work that we do, even if we all have completely different jobs. And so to that extent, the time you and your organizations have invested in you being here is professional well-being. And so I'm gonna talk a lot about, first, key bits of data that we all should have ready to go at the top of our minds. And then talking about what is a systems approach to professional well-being. This is not a you problem. It's not you, it's the system. It's everything necessarily outside of you. Let's talk a little bit about that. I want to start by actually giving you a sense of why I'm speaking about this work. This is a little bit of a busy slide, but I highlighted the part that I want to emphasize. Now, I worked in diverse care settings, the VA, the city hospitals, the academic centers, county hospitals, top cancer centers, community networks, research institutes. This is a natural progression of me professionally. But I developed this professional focus in healthcare professional well-being, actually tied to my origins, if you will. I'm a second-generation medical oncologist. My mom's a medical oncologist. She practiced in rural Pennsylvania for almost 30 years. And I'm a third-generation physician. And so I grew up around medicine in one way or another. I can't tell you the number of pagers that went off at my wedding. Nobody flinched. No one was clutching their pearl. I'm also married a doctor, so no one was clutching their pearls. No one was like, oh, nope, didn't even notice. It's a way of life. It was just a part of what we grew up with. And so a few years ago, my dad was playing with our kids, and then he came up to me and he kind of said something to me in passing. It's like, we shouldn't push the kids towards medicine. We should encourage them to, look at other careers. And then he went about his day. To someone observing this interaction, that is, okay, whatever. He said something and he went on. To me, it stopped me in my tracks. I remembered, it's one of those moments where you remember what was around you. You remember what you were doing, what others were doing. Here was a man who loved his work. The only thing that got him to retire as a nephrologist were his grandkids. Loved his work. And he's saying that the most precious things in his life, he wants them to look at callings that that isn't what he had chosen for himself. That was a pivotal moment for me professionally. And that was when I decided to just slightly pivot away from the work I was doing, which was resistance mechanisms in NRAS mutant melanoma, and actually focus on the people in our workforce. And so when we're talking about healthcare professional well-being, what we're going to walk away with today is clear understanding of what it is we're talking about. What is the evidence behind it? And where are the places and ways where you can start seeing progress, a change in the trajectory of burnout in medicine? We have to make sure we're talking about the same thing. Burnout, I heard it in like a commercial, I heard it on sitcoms. The word has been thrown around so much that it kind of loses its meaning when it becomes part of the colloquial, just vernacular. Emotional exhaustion. This is when you feel depleted, when you feel exhausted to carry on with your day-to-day responsibilities. Depersonalization. When you feel disconnected, there is an increased mental distance between you and the work that you're doing, from the people that you're taking care of. You start to, the plight of someone doesn't really affect you. You become more cynical. And reduced professional efficacy, reduced sense of professional accomplishment. These are the three key dimensions of what burnout syndrome is. ICD-11 set it up as an official diagnosable occupational phenomenon. It's a syndrome. It's not quite an illness, but it is officially in our code book of diseases as burnout. What it's not, and this is where I want to make sure I highlight the differences between an occupational burnout and other mental health conditions. Burnout is not the same as adjustment disorder. It's not the same as depression, anxiety, any mood disorders. It is not the same as that. Burnout is also something that's specific to the occupational setting. And the word is not applicable to other areas of life, however important they are. And so when we're looking at professional well-being, we think of emotional exhaustion, depersonalization, and that reduced sense of professional accomplishment. Snapshot of the numbers. This is just a part of the picture. The prevalence of burnout is high. 57% of oncologists, this was in 2023, met the criteria. Our PAs, 53% of med-onc PAs. It was the highest burnout rate across all PA subspecialties. The nurses, depending on which study you look at, is anywhere from 30 to upwards of 56% have meet one or more criteria for burnout. Data point number one to take home. Healthcare does not have a resiliency deficit. What do we mean by this? This was a 2020 study that looked at the general US population, and it captured the resiliency scores across different professions, and it compared physicians and other roles across the country. Some of the key findings. At baseline, the resilience score among doctors was higher than the general population. It was one of the highest, actually, of the different jobs out there. There was some value to being more resilient, because what they showed was that with each point that your resilience score went up, there was actually lower odds of burnout. But they also showed that nearly a third of the docs who had the highest possible resiliency score still met the criteria for the burnout syndrome. So the key take-home messages from this are that when we're talking about burnout in healthcare professionals, though this study is specific to physicians, you're talking about a workforce that is resilient to begin with. We made it this far. So we're resilient people to begin with. There is some value to working on your resiliency skills. There seems to be some level of protection that it confers when you're able to better cope with stress, better cope with chaos. But higher resilience isn't actually the answer, because the root cause of the stress, of the chaos, is actually not the resiliency deficit, right? Otherwise, these docs who had the highest resiliency score, why would they be burnt out? So spending time on personal wellness, mindfulness practices, physical activity, these are all evidence-based practices for your own health and well-being. They are directly tied to your individual health and longevity. They are not the heart of how we tackle professional well-being. We have to start using a language that actually reflects what professional well-being is and burnout is in a clinical psychology and organizational psychology dictionary. Let's start with cognitive task load. How many of you have spent time thinking about cognitive task load? This is the amount of information that's stored in your working memory at any one time. Your working memory is a finite resource. It is no different than the working memory of the laptop that actually most of you are not using. Kudos on not breaking that out. It's a finite resource. And so cognitive task load, each task, however small it is, consumes a portion of the memory. We have to start thinking about our day-to-day work life as a series of individual tasks, however small or large they may be, and the cumulative of those tasks is what the workday is. There was a 2020 study that was a national survey, and it was meant to measure task load amongst US physicians and the risk of burnout. And so they used this very interesting measure. Apparently, the group that doesn't want their workforce doing stupid things is NASA. NASA does not want their astronauts doing stupid things, silly things, when in outer space. Here we are, a room full of professionals working with very dangerous medications. Shouldn't we have a measure that actually quantifies the burden of the tasks that we are assigned on a day-to-day basis? So NASA developed this task load index. With every task that's going to be put on an astronaut's plate, they assess the mental demand of that task, the physical demand, temporal demand. How long does it take? Other time-related elements. How much frustration does it cause? What's the effort? And how does it affect performance? Every single task. There's no click that's too small. When this study team administered the TLX to a little over 5,000 physicians, at least 44% met the criteria for the burnout syndrome. And there was a very clear relationship between the task load and the prevalence of burnout. What they showed was that every 10% decrease in the task load lowered the odds of burnout by a third. Just 10% decrease in the task load lowered the odds of burnout by a third. Suddenly, you're looking at how paying attention to each individual, everything you do every day can impact something as nebulous as burnout. The data backs your perceptions. There are a lot of us in this room who spend time in the electronic health record system. This was a study that was just published. And they looked at over 17,000 oncologists across the country, practicing different subspecialties of oncology. Most of them were med-oncs, and across about 43 million visits. And what they showed was that when you look at 2019 to 2022, still a relatively narrow window, but 2019 to 2022, just in those years, 3 years, there's a 19% increase in the EHR message volume across all oncology specialties. When you looked at the medical oncologists specifically, they were consistently the highest ranked for each of these EHR task load burden metrics, whether it's message volume increase, whether it's in the number of messages that were from patients. So remember, message volume is from anybody. The number of 23% increase in the number of patient messages, just in this 3-year period. Total time spent within the EHR, time spent just managing the inbox, and time spent after hours, pajama time, like it's something cute. This is quantification. This is data-driven professional well-being. What you perceive in your day-to-day work life, the evidence backs it up. As we launch into what can we do about it, we have to get into the right mindset, right? Because burnout in medicine is right up there with climate change and world peace. You're like, okay, what am I supposed to do about it? I'll bring my own bag to Target next time, which I never do. But the point being is, what do you do about it? Burnout seems like such a nebulous concept, right? I want to show you a snapshot of a study we just published, and then I'll come back to it later. But this was a 10-year interval study. We did the survey first in 2013, and then we repeated it in 2023. This is a study of medical oncology fellow physicians who are training in medical oncology. And we invited every fellow in the United States to take the measure, and we had 71% respond. I don't know how many of you do surveys or other requests for feedback, but that is an enormous response. Fellows in 2023, oncology physicians in training in 2023, showed that the prevalence of burnout actually went down. It was 34% in 2013, and it was now 20%. Oncology fellows reported that their satisfaction with their work-life integration improved. It was 34% back in 2013 were satisfied with their work-life integration. 2023 was 50%. And then we asked the question, would you choose, if you were given the option, would you choose to go into oncology again? And look at this. In 2013, 10 years ago, it was 89%. And 2023, 93%. So 93% of the new docs that you're seeing in your practices, that you interact with, they probably were among the people who took, not probably, they are among the people who took this survey. 93% of them said they would do oncology again even if they were given an out. So you're talking about a population of health professionals whose experience and whose trends in burnout actually went in the right direction. There's a lot to learn from how did this happen? What were all the things that fell into place to actually pivot the experience for something that's seemingly as insurmountable as burnout? When you distill the evidence out there, there are really three key buckets of action on what it takes at the systems level, whether it's your clinic, whether it's your individual clinic, whether it's your entire clinic, including all the other clinicians, whether it's your practice, whether it's your health system. The three-part systems approach is meant to actually take what we learned from the evidence and action on it. The very first thing to do is to level set. We cannot have another organization or another leader look at healthcare professional well-being as a personal problem, a you problem, something for you to address with your primary care doctor or a therapist or whomever. We have to establish a data-driven framework on what it is we're talking about, and we have to have that language spoken across the organization when we're talking about our workplace experience. So it's less about the meditation retreat and more about cognitive task load. We all have to have that data at the tip of our tongues or heads. Half of the oncologists are burnt out. Our PAs, med-onc PAs especially, have the highest burnout in all of all the PA subspecialties. These are facts we have to have ready to go for anybody who will push back and say, well, I don't know if it's really that much of a problem. Da, da, da. The second thing is we have to have the fact ready to go that healthcare does not have a resiliency deficit. Healthcare professionals, study after study shows, have among the highest resiliency scores already to begin with. It's great to encourage more and resiliency habits, but we can't have our organizational efforts to take care of our people be centered entirely around journaling. We can use the work that's done to date. This one is a visual from the National Academies. This is a visual out of Stanford. This one is out of the Mayo Clinic. You're not meant to read exactly what's in there. I'll go into it in a few seconds. But the point being is the frameworks they've already been characterized by others. Let's pick one and dive into it, and you can see if it makes sense for your workplace environment. What does professional fulfillment, professional well-being comprised of? 3 main domains. You see personal resilience here. There is a place for personal wellness in professional well-being. But as you can see, it's not everything. In fact, it's not the majority. This is about an 80-20 split. Professional well-being is about 80%. I say organizational factors, organizational systems level factors outside of the individual, 80%. And then 20% is how you cope with what you're around. What does culture of wellness and efficiency of practice mean? This culture of wellness, do we have a mindfulness moment to kick off the 18th meeting of the day? That could have been an email. Culture of wellness is, do we promote and do we have an organizational environment that actively promotes your professional growth, care of yourself, and compassion for self and others? Is there psychological safety? Are people afraid to ask for help? Are people afraid to make mistakes or to say that they made mistakes? Efficiency of practice is exactly what it sounds like. And this isn't specific to any one role. These are domains that are relevant across roles in any healthcare setting. What are the processes? This is an operational element. Are you having to do something that could be readily automated? Are you transcribing what a patient reports to you in response to a question into the medical record system? And personal resilience are those individual skills. How are you able to cope with what's happening around you? We have to reframe well-being as being actionable. We have a group here of healthcare professionals whose experience in the workplace has successfully pivoted in the right direction over the last 10 years. When we take a look at how this experience happened, we look at not just burnout as an overarching domain. It's very hard to do anything with a burnout score, right? I mean, it's good to know that it's 40%, 50%, but okay, what am I supposed to do with that? The driver dimensions of our workplace experience bring us close to actionability. And what you see here in this matrix, in this work out of the Mayo Clinic, actually almost 10 years ago now, is individual driver dimensions that inform our workplace experience. You see that workload and job demands, the meaning in work, organizational culture and values, efficiency and resources control and flexibility. When it's more optimal, it's not all bad news, right? And when it's more optimal, you have what we look for, is an engaged, thriving people taking care of those with cancer. When it's less optimal, you have the components of burnout. And you have turnover and tensions. And so when we look at these domains that make up the workplace experience, you can suddenly see that each of these, there isn't like a catastrophic event for each of these. Meaning, if a patient has a transfusion reaction and, or codes in the infusion area, we convene, right? We convene a group of people and we work through it. We fishbone it to oblivion and figure out what happened, what can we do about it. When we're talking about our workplace experience and professional well-being, it's not a singular catastrophic event. These are the 500 inefficiencies, the 500 micro frustrations that each individually doesn't have an incident command or doesn't have any kind of a platform. But at the end of the day, you suddenly have 30, 40, 50 different micro frustrations, sources of micro trauma that happen throughout the day. We're all taught to just kind of shake it off. We shake things off all day, every day. This Muhammad Ali quote captures this microtrauma concept spot on. It isn't the mountains ahead to climb that wear you out, it's the pebble in your shoe. Each micro frustration, each micro trauma is a pebble in your shoe. Before you know it, you're walking into work, you feel that exhaustion, that weight, you're not sure what it is. Nothing bad happened, I have a great family, I have a paycheck, my patients are, I like my patients, they like me, why am I feeling this way? Well, it's because you have 80 pebbles in one shoe, 100 in the other, and 200 in the backpack. The aggregate effect of the individual inefficiencies, individual sources of microtrauma matter. That is what we have to actually focus the lens on in any organizational strategy. I have a sign in my office, and it says, it's from an IBM scientist many years ago. In God we trust, all others must bring data. Healthcare professional well-being is can be as objectively measured as any lab test out there. There is a validated, psychometrically validated, normalized questions to assess each of these driver dimensions of well-being. Check the perceptions at the door. I always appreciate leaders who want to say how their people are doing, and I'm always happy to hear that. I want to see the numbers to back it up. And by having validated measures for each of the driver dimensions of professional well-being, you can now know how your people are doing at scale. Not just the handful who are just bubbling rabbits blowing, they're just rainbows and unicorns all day. They're just so delightfully happy. I mean, good for them, but I actually want to know how everybody's doing. And so recognizing that these evidence-based driver dimensions have an objective way to measure with a numeric score that's normalized and standardized for national benchmarks on how your people are doing is invaluable. It's worth its weight in gold. Why do I say that? Because now you have information in front of you on where you're knocking it out of the park as an organization, where your people are at risk. And for at risk, I mean not just how they're feeling, at risk for turnover. Our colleagues in HR measure turnover diligently, right? Those of us in the cancer space, that's after the fact. We want to know turnover before it becomes turnover. Turnover intentions. How likely are you to leave your job in the next 12 months or 24 months? That's how the single question is. And the person responds from not likely at all to extremely likely. So you get a snapshot of what portion and proportion of your people are considering leaving. You want to know. What is the likelihood of you reducing your clinical hours in the next 12 months or 24 months? That's another question in that 2-question section. So you get a sense of, are people looking to cut down on their time, spend less time? This is how you make burnout actionable. What do these questions look like? My personal favorite is this organizational values and culture and personal organizational values alignment. This isn't about, who you vote for or what you pray to or, this has nothing to do with that. This is, look at the question. How true are the following statements about the conditions in your practice setting where you're primarily practicing? My input is valued in important administrative decisions. Our organizational goals and values align well with my goals and values, i.e., you want to provide superb care for your patients. You want to provide safe care for your patients. You want to be able to get things done. Is the organizational actions supportive of that? Administration values my clinical work. These answers, this section will give you one aggregate number, and you can suddenly you have a pulse on how your people are doing, whether it's 10 people in one clinic or 1,700 across a national network. We're talking about dimensions that can seem kind of very soft, right? Actionable drivers and validated measures. Let's talk about why things like feeling valued matter. This was a study that looked at those individual driver dimensions in that matrix and the prevalence of burnout. The top line here is the prevalence of burnout amongst clinicians who didn't feel valued. And the orange line here is the prevalence of burnout amongst clinicians who did feel valued. Look at this delta. This was adjusted for all other factors, years in practice, gender, age, work hours. The difference in burnout between those who didn't feel valued versus those who did was nearly double. This is why measuring things like feeling valued matters. You'll also notice that those who feel valued, this curve isn't at 0, meaning you can feel valued and you can still be burnt out. That's why we measure across those dimensions, because it's not just the valued part, it's something else. What's going on? Next key take-home point. One size does not fit all. We'll continue the trend. This is precision medicine, but for our people. This graphic, I'll zoom in a minute so you can see what the text is about. But this graphic shows you the stressors by occupation. What did the physicians report, the APPs and non-clinical allied health personnel, nurses? When they ranked their stressors in their workplace, this is the general layout of how each role ranked their stressors. There are things we all have in common, but then there are also stressors that we don't share. We can't do the same thing as an organizational, on an organizational level for everybody. You have to pay attention to the unique needs of each role. And so where we have commonalities, we all want great, well-functioning care teams, we all want good leadership and management, and we all want this values alignment. We also have to recognize that the advancing professional well-being at our organizations, it has to happen as an organization. This is not the work of one person. It is not a side gig on top of your actual job. And we have to recognize that where the ROI is in investing in well-being actually comes when we do organizational interventions. It's not, let's buy everybody a 4-day retreat in the woods, but it's introducing task load as part of the checklist for the development or the review of any initiatives. This becomes profoundly relevant in the work in the advocacy space. Because when you're I mean, I was looking down the list of federal advocacy priorities and state advocacy priorities. I would challenge you to add a bullet point for each of those and talk about the workforce impact. How would a more streamlined access to drugs look like if prior authorization wasn't nearly as burdensome? What would the task load reduction be? How much time would we give back to our healthcare team members, multiple members of the healthcare team, to spend with their patients, or frankly, however they choose to? Maybe get some lunch for once during clinic. Take a bio break. When we're looking at advocacy priorities across any policies, I would challenge you all to put into words the people-facing impact. We already do a great job of capturing the patient-facing impact, but our care teams, as well as any professional who intersects with that issue, let's start quantifying that. We will reduce the task load for the pharmacist, for the physician, for the APP, for the nurse, if we allow for easy access to anti-nausea medications or easy access to frontline approved therapies. When we're talking about, developing well-being leaders, it's because we really need this ambassadors for this work. We need folks to be able to see when they're developing an initiative that, okay, that's a great idea, but you're talking about now 3 additional things that the nurse has to do when she's interacting with a patient. You're talking about 4 additional steps that the physician has to take on top of what they're already doing. Draw a light to that dimension of the work being done. That will make you the area well-being leader. And then take a look at some of the work that's already been done. I'll highlight one of these strategies as I wrap this up. We did a town hall at last year's ASCO annual meeting on organizational strategies to tackle healthcare professional well-being and burnout and oncology clinicians. And we came up with 6 key strategies. I'm going to highlight the first one because I think this is actually going to be the most impactful. Eliminating low-value administrative work, right? The goal of this was to identify and de-implement unnecessary steps in the current state. And as I'm typing this out, my little, word dictionary does the little red squigglies. Apparently, de-implement wasn't in my dictionary. So that was task number 1 for me, and I would present it to you as task for all of us. Add de-implementation. Add de-implement to your dictionaries and to your practice dictionaries and your workplace cultures. Just because we've done something for how many ever months or years does not mean we have to keep doing it. Just because the evidence out there showed that, assessment X made a difference, we have to know if it's making a difference in our patients. If the answer is no, kindly take it off of people's plates. If the nurse has 7 questions to ask a patient, and what he or she is essentially doing is writing down the patient responses and plugging it into the system, that can go to the patient through the medical record as an electronic survey. Or that can go as a paper form that the patient fills out in the waiting area, and it can be just scanned into the chart. Your professionals, if they're serving a transcribing function or some data acquisition function, these are some of the ways where de-implementing has to be the very first thing we do. Those cups are running over, those plates are full, pick your metaphor. Imagine how your people will react if what you're about to announce is not things for them, more things for them to do, but actually a campaign to start scaling back the low-value tasks. How do you do something like that? I would point you all to one of the AMA resources. It has a nice framework. It just gives you a roadmap so that you can have a beginning, a middle, and an end. And the program is called, Get Rid of the Stupid Stuff. Gross, the gross module. And they talk about what are things you can do to identify low-value work. My favorite task is to crowdsource. Get input from people who may feel like they're not actually listened to. If you read the annual surveys that your workplace does, and if there happens to be a place for free text, in my Wellbeing leadership roles, this is one of the first things I do, is to read through the free text comments, and gosh, people do not hold back there, by the way. The number one comment that has been there in a major cancer center, in a large community practice network, in a research institute, the number one comment: I put this down every year, but nothing ever seems to happen. So, get the low-value task ideas from us directly, the frontline folks. Here are some of the example questions that can help launch a campaign like that. Get people thinking about each of those micro-trauma, each of the sources, each of the pebbles in their shoe. That is how we're going to make the difference in healthcare professional well-being, is frankly understanding what are people doing now that they, in their professional lens, feel they can not do or do differently, and it won't affect patients. And so taking that action and then measuring impact, these can all be readily done, both in the task load index, but also closing the loop. If the number one comment in an employee survey is that I say something, I bring this up every year and nothing happens, that's a problem that's a process issue. There's an issue with closed loop communication. And so eliminating low-value work and de-implementation would be the number one thing I would encourage you all to start looking at when you go back to work on Monday morning. It's going to be incremental. If the causes of burnout are not a singular catastrophic event, that means we have to actually start paying attention to the things that we brush aside, or the things that we just kind of have trained ourselves to work through as a self-preservation. But it can be done. It can definitely be done. And advocacy and policy are central to this effort, both in demonstrating impact of good policy on the carers, the healthcare professionals, but also, frankly, I'll wrap it up with the fellows' experience, right? How did we change the course of burnout in fellows? And it was accountability. We have a couple of program directors in the house. There is a central entity that regulates the professional workplace experience, that sets standard for the professional workplace experience of physicians in training. There's an accountability there with enforcement. No, who's there to take care of us once we're out in the workforce? We have to think through that from a policy standpoint. What does that look like? What does accountability look like for sustainability of the healthcare workforce? To be continued. Please stay in touch. I'll stop.